and welcome to Mind Your Health. Dr. David Burke and I are excited today to introduce our guest, Dr. Tempest Allen. Thank you so much. You are a practicing OB-GYN at Beaufort Memorial and a relatively new transplant down here. So thank you for joining us today. Just to give you a quick tease, we're going to be talking a lot about hormones. And I can tell you, as a 72-year-old who has children who are in their 40s, 30s, and 20s, it's a big topic right now.
Yes,
it really is. So thank you for joining us.
You are a younger woman before menopause and you've had a hysterectomy and had your ovaries removed, that by being on estrogen replacement, you decreased your risk for heart disease, markedly, up to 50%. You decreased your risk for diabetes. You decreased your risk for bone loss and developing dementia, which is so key.
Mind your health.
You got to mind your health.
Mind your health.
Treat yourself. You got to mind your health.
Tell us a little bit about what brought you here.
Yeah, I'm an OB-GYN. I've been practicing for 26 years in Michigan and was really big in the academic side of it. Taught at Homer Stryker School of Medicine in Michigan and oversaw OB-GYN residents and medical students. And just, the snow was getting to me and kind of wanted to focus a little more on postmenopausal women's health.
Okay.
And getting back to just actually bread and butter, taking care of patients.
Taking care of patients. Was it fun doing the academic side? I think that sounds interesting.
Yes, ma'am. And it was a huge.
She called me ma'am again.
It was very.
I'll leave it and let that rest.
Well, she's practicing Southern.
So
I'm trying.
I know.
I think the perfect segue is learning from that academic side how far we've come in treating postmenopausal, treating female patients in the last, 50 years, 40 years?
Absolutely. Absolutely. It's been a huge transition. In 2000, we had a big study that kind of blew up. It was called the Women's Health Initiative. And we kind of took everybody's hormones away. And it was a study, and it was National Institutes of Health put it on. And it basically said that that hormones were not as great for women as we thought. And what we've found in the last 4 or 5 years is that wasn't true. A lot of that data was a little misconstrued.
So I'd like to even go back to basics. If we're going to talk about hormones in women, brief overview of different ages. I start out with 12, 13, misread, taking us through kind of the end of life. Just basically, I'm assuming that we all experience hormone differences and ebbs and flows. Just sort of an overview of what a hormone really does and why it's so important to us.
Yeah.
As women. We will do testosterone another day.
Although testosterone can help as well.
There you go.
Yeah, women here testosterone.
Yeah, I knew that.
Well, you did. Of course you did.
Well, obviously, when we're born, most women will start menstruation around age 12, and that's when our hormones. We get our secondary sexual characteristics. We get our breasts.
Right.
We can start to have babies.
Have babies. I got it.
And you get the eye from the teenage girls. If you've had girls, yes, ma'am. And throughout, and then you get into your reproductive years. And then we used to think menopause, started early 50s. And we would say, the definition of menopause is when you haven't had a period for 12 months.
Okay.
Now we know that this perimenopausal period, which can last 10 years before.
Oh, wow.
You start, it really can start early. It can even...
What is it? What does perimenopause even mean? What's happening?
Right. In perimenopause, that's when women, their periods can change a little. They can get, we call it brain fog. Sometimes, forget it. You're like, where's my phone? And it's in your hand.
Right.
Or where are my car keys? And they're in your hand. And your periods can change, your moods can change.
Okay.
And sexual health can change a little bit. Libido can go down a little bit.
Okay.
What we know now is that can last for 10 years.
Oh my gosh.
And the normal menopause can be anywhere from 45 to 56.
Did you know when your wife was going through menopause?
I refuse to answer on the grounds that they would be later. Yes, yeah.
Okay.
Karen was very in tune, and still is, to her body and her regular
Okay.
cycle. She was like clockwork, so she
Okay.
knew things were changing.
What are some symptoms? I mean, when I hear that, I hear hot flashes. And because when kids are all in their 40s and all think that they're all going through perimenopause, it's absolutely priceless. I'm like,
Right. So anyone over 45, they could potentially be in menopause. So,
Okay.
and because those symptoms can start 10 years earlier, some of the symptoms could be hot flashes, mood swings, decreased libido, night sweats, waking up at 3 a.m. That's
Okay.
a classic one I hear. Itching. I've had a lot of patients say their ears itch, their
Yeah.
hair is starting to thin. There's a whole myriad. We have estrogen receptors even in our joints.
Okay.
Joint pain can be one of them. So it's tied to everything. It really is.
So let's move on to, so if a woman at 45-ish starts feeling symptoms like that, does that come to the doctor? Or is that, I'm getting older, my body's changing,
whatever.
just you deal with it?
Right.
Not,
And that is, no, I know, exactly.
And for so many years, a lot of us as OB-GYNs, a lot of us were trying to say that's kind of part of aging. Now we know there are a lot of things you can do to help with that. I would highly recommend you reach out to your provider and kind of start that conversation, because there are a lot of things you can do to help with sleep.
Yeah. So what I hear you say is there's a natural trajectory of hormones and things you can expect.
Yes, ma'am.
But just because there is a natural trajectory doesn't mean we can't intervene and make our quality of life better.
Yes, ma'am.
So what does that look like for women?
So basically getting, in our mid 40s, making sure that we're getting enough protein, making sure that we're getting our yearly labs. So just because you don't necessarily need to come in for a pap smear every year, you do need to see your OB-GYN every year so you can discuss other types of interventions. If you have decreased libido, there are a lot of things we can do for that. Even
Is that true? Okay. All
Yes,
that kind
ma'am.
of stuff, sure.
Even getting your hemoglobin and your ferritin checked, that's been linked to sleep disturbances.
Okay.
Sleep
got it.
studies,
Got
sleep
it.
apnea. There are so many things that you can do early on. It's just not about a pap smear anymore.
And I hear from a lot of my kids, I just feel like I have a little bit of weight gain, or my body is redistributing where the fat seems to be. I mean, I'm being really honest. I mean, and, or I just feel like I want to burst into tears, or everybody's bugging me. My husband's walking down the hall breathing, and I'm like, I mean, that's what I'm hearing.
It's absolutely true. There was just recently an article in Self magazine, and we have estrogen receptors in our brain, and actually those receptors, when your estrogen levels start to drop during perimenopause, you can mistakenly be diagnosed for depression, anxiety,
I believe that.
when really a little estrogen may help with that.
So let's talk about some of the interventions that are practical. So I come in as my 48-year-old daughter. She's still having periods. She's full-time working. She's really happy, but she just must know she can improve her quality of life. Those kids are growing. What do we do?
Yeah, so there's some basic things you can do. First of all, kind of track those symptoms. When are the hot flashes happening? Sleep, again, make sure you're getting the labs.
So sleep is huge for you.
Huge,
Okay.
huge, because that's when our brain, that's when we refill our gas tank.
That's right.
Right?
Scrub our
So yes, absolutely. So if you're not getting sleep, your cortisol levels are going up. And if your nighttime cortisol levels are going up, you're burning less calories.
Okay.
If you're not getting that deep sleep.
Yep.
and you can actually increase your adipose tissue. And that's where you get into the belly fat.
Exactly.
There are even some studies out there that are saying that maybe even being on a little bit of estrogen replacement therapy or hormone replacement therapy, because you're getting the sleep, cortisol levels go down and you actually can lose weight.
Well, so 100 years ago, when I had a hysterectomy when I was like 43 or 44, something like that, and that time they put you on hormone replacement therapy, and my doctor just kind of went under the radar and said, "Here are the studies in the 2000s, and we feel like if you just continue to take your hormone replacement therapy and lower it according to your age, that the benefits symptomatically, okay, may outweigh the risk." We don't know. What do you want to do?
So that was the smartest thing your physician ever did for you, because what we found is
Thank
that
you, Beaufort Memorial.
if you are a younger woman before menopause and you've had a hysterectomy and had your ovaries removed, that by being on estrogen replacement, you decreased your risk for heart disease markedly, up to 50%. You decreased your risk for diabetes. You decreased your risk for bone loss.
Did not know
And
that.
developing dementia, which is so key.
Well, that is funny because osteopenia, osteoporosis. I mean, I feel relatively healthy.
Yes.
And I'm just, that's where having a relationship with your doc's so important. And you've always said that.
Yeah, because I see all those in my practice. I see all those symptoms,
Yes.
and now you kind of touched on it. I hear a lot of, well, I get all those, the cardioprotective and all that, and the symptom relief, but I've also heard, uterine cancer and all the other cancers with the estrogens. So how do you counsel people of that balance?
So if you do not have a uterus, you don't need the progesterone component, estrogen only. But if you do have a uterus, you do need estrogen and progesterone. The progesterone helps prevent a thickening of that lining. In the 70s and 60s, they would prescribe estrogen only. And what we found is if you didn't add the progesterone to help thin the lining, that you could markedly increase your risk of endometrial cancer. But now, going through this data, because the last 5 years, for 26 years, we told women estrogen, progesterone can increase your risk of breast cancer.
Right.
And what we found now, they took a look back at that study, and what they found is that a lot of that information wasn't as statistically significant as we thought.
Okay.
So actually, being on estrogen and progesterone, if you start it again before the age of 60 or within 10 years of the onset of menopause, it can actually be very beneficial for your quality of life.
Absolutely fascinating. So we're on estrogen. There are lots of ways to get estrogen. I'm just going to ask a semi-controversial question, but I think it's really interesting. My Instagram feed, my algorithm, my spa, a lot of places now, it seems to me there are a lot of people who have use this estrogen, get this blood test. What about this? How about testosterone? How about this? How about that? And I'm just curious from a physician's point of view and a female OB-GYN, I don't know. I'm just curious. How about that?
It's a great question.
What
I would say. So, as we know, there's the American College of OB-GYN, and they have great patient resources as well as the Menopause Society. And I would highly recommend that patients look into this. There's also an author, her name's Mary Claire Haver, and she wrote this book called The New Menopause.
Okay.
And she just put out a book called The New Perimenopause. I have no affiliations with her, except she's kind of a rock star.
Right.
She's a board certified OB-GYN, and she kind of dumbs it down.
Right.
And
love a good dumb down. So we get it.
Yes, ma'am.
That's right. Exactly. Yes, exactly.
So what we know now is that, you gotta, it's a huge relationship with your provider, and if you have a good provider who you trust, you sit down and talk with them. You know, the FDA, there are only a few approved FDA bioidentical hormones. So bioidentical hormones, what that basically means,
Yeah, what does it?
is that is your body, it's what your body produces. So there's a progesterone called prometrium.
Oh yeah, this is all your stuff. Yeah.
Which is basically what your ovaries produce. And that is available, it's FDA approved, and insurance will pay for it, which can be very cost effective for a lot of patients. And then estradiol, there are bioidentical formulations approved by the FDA. The transdermal seems to be the way to go. Now we found that it's better for
Is that like
protection.
rubbing it on, or
You can do a
patching?
patch.
Okay.
Or that's a great question. They have a cream available. They have a patch. They have an oral estradiol as well. What we found is that the transdermal can decrease the risk of blood clot and stroke.
Got it.
In women, and it might be a little better for bone health.
Okay.
It bypasses the liver, so it won't affect your cholesterol if you have blood air issues.
Okay, got it.
So like a Vivel dot. So there's a national shortage right now because this has just exploded, the patch, I'm sorry. And there's also something called Estrogen.
Okay.
So if you're wanting something that insurance will pay for, that's FDA regulated, that's your way to go. Talk to your provider about it. Now, not everyone can use patches. There are contraindications, and then we get into some of the creams. This is where it gets a little dicey. You have to have a compounding pharmacy or a provider that really knows what they're doing and is willing to work with you, and that can be it's buyer beware there.
Okay.
I would recommend you consult your provider that has and I would do your research.
Okay.
You don't want someone that doesn't do hormones on a regular basis or doesn't have a little bit of medical training. I'm sure you would agree. Writing these prescriptions.
Well, it is really interesting because I hear everything from anecdotally just from this group, because again, it's my kids group, I'm going to start on a GLP-1. They said it'll help my hormones, and I'm going to start on this. I'm thinking about this. I'm supplementing with this. I'm doing this. I'm doing this. I'm doing this. And I don't even know what's reasonable. I'm curious about it and I want to understand.
Right.
But for me, I've always gone to my OB-GYN as my professional advocate.
Yes, ma'am. And it doesn't necessarily have to be a physician. It could be a nurse practitioner.
Sure, they were great. Yes.
A lot of family medicine docs, like Dr. Pellegrino, who is actually a huge advocate for obesity medicine. Okay. I work closely with her. I've referred a lot of patients to her. But I would recommend that you see someone with a medical background, at least.
And what I hear you say, too, is it's individualized. What is good for me might not be good for David or Heather or Tempest or Lindsay or whoever.
Absolutely. And when it comes to testosterone, you had brought that up. Right now, testosterone, the only FDA-approved indication is for hypoactive sexual dysfunction in postmenopausal women. However,
explain that.
So I know it sounded
like
fancy, didn't it? I memorized that for you. Just a decrease, as we age and there's a lack of estrogen, there's less blood flow and less collagen.
Okay.
So there's a lot of evidence that evidence-based medicine, that's the big catchphrase now. So there are some studies that say that that vaginal estrogen can help with hypoactive sexual dysfunction. So decreased libido, decreased desire.
Okay. It can
decrease orgasm.
Okay.
So But buyer beware again, because now we have there's some studies ongoing, because this is exploding right now, that says it might actually increase quality of life,
Oh.
the testosterone. And
Are you seeing a lot of that in?
So yeah, the vast majority of the women that we compound for will have testosterone in the cream.
Oh, is it interesting? Yeah, you kind of have seen the trends from a pharmaceutical point of view.
And you have to have a good compounding pharmacist. So, like I said, buyer beware. So, you got to have someone that you really trust and someone that's really gonna compound.
Well, I think the best point I got from what you were saying is the people that are doing it regularly. You can't just go off into any pharmacy anywhere in the country and just say, "Can you make this for me?" It's really a specialized art.
And I use, which compounding pharmacy are you with? Tell me again. Which one do you use?
I'm with Burke's Pharmacy here.
He's the owner of
I use you a lot.
Yeah, because he's the BES best.
I use you a lot. Have you noticed that I'm calling? And and you need to find someone that you trust and someone that you work with, because it's a huge.
Then do you make that up and you say, okay, for Debbie we're going to do a dash and 3 sprinkles?
I call and get a lot of input from these guys. They help me so much with my OKT patients, especially.
Well, this is to your point. Yes, they are individualized.
Okay.
So the prescriber is looking at lab values, your particular symptoms. So yours is different than your daughter's. Is different from the neighbor lady. So it is individual.
So it's such a valuable resource when you find a compounding pharmacy and pharmacist that helps so much.
We talk about that all the time, about developing a relationship, and people don't use David and his crew as a resource as much as they can.
Oh, I call every day.
And that's so funny, because we talk about that sometimes too. Can I make a real quick pivot?
Yes.
I'm curious what the recommended guidelines are now for annual visits at different ages. So when do you recommend, I'm a psychologist, so I work with young girls as well as older adults, and I get such mixed messages. Come every year, come every 3 years, no PAP, yes PAP. I took my 14-year-old daughter and they said they didn't want to see her. So what is the guideline from a female perspective?
If someone's having no issues, typically, if they're going to start birth control, we recommend they come in, not necessarily for a pelvic exam, just to chat.
Okay.
But no one needs a PAP before the age of 21.
Oh. I did not know that. Very interesting. Okay,
And
Pap smear around 21.
And then after that, I recommend a yearly annual.
Okay.
And then after menopause, you definitely need, you might not need a PAP, because those recommendations change. You can go, between the ages of 30 and 65, you can even go to every 5 years.
Oh, wow.
But that does not mean you don't need a yearly annual.
Okay, well said. Okay, well said.
You need a yearly PAP and pelvic, and to discuss interventions.
Okay, and then I'm over 70. What about 70 on? Because we're living.
You need a
tonight.
yearly PAP, or not a yearly PAP, but a yearly exam.
Okay, period.
To discuss your bone health, your skin health. Have you been going to the dermatologist? Have you been getting a mammogram? Have you been,
Yeah. Upkeep. I like that. Housekeeping.
Yes. And, so many women, they start to lose partners too,
Okay.
Sometimes they just need to talk to someone.
Yeah.
And you
that's
can catch a
probably
lot
where-
of other things.
It is true. It's really interesting in working with young folks from a psychological point of view, and then with older women, meaning 50 and older. It is interesting because I feel sometimes like I'm talking to a 16-year-old again, because we're having the same conversations. What about? Should I? How do I? It's really kind of fun. And do you see that a lot in your practice too?
Yes. Yeah.
Well, I also understand the difficulty, though, of, sitting with you, because for that once a year, I need to talk. My partner just died. My this, that going on. But knowing that you're going to see 25 patients that day, and knowing that, I'm on Medicare, so you're getting $12 for my visit, and difficulty.
I should probably pay more attention to that. I don't. I kind of sit there and make a memory, I think, a lot of times.
So the reality of being able to discuss everything I want to discuss is difficult, because I hear that, and I'm thank you that that you do that. That's the goal, but it is difficult, especially.
It can be.
Yeah.
It can be. A lot of times you can pick up just muscle wasting, which is so important.
Oh.
Because there are some newer studies that say that if you get enough protein in your diet and even enough fiber, it can decrease the risk of dementia in men and women. There's a new study out about that. It's just exploding, and every day I learn something new.
Yeah.
I call you guys all the time, and through collaboration, I'm learning.
And go ahead.
So where we're going to go to, what our focus part of this podcast is the food.
Yeah.
You've talked often on food as medicine, and it's just exploding of the it used to be just a well-balanced diet on the plate. Well, it's way bigger than that.
Right.
Well, to everything you're saying, we have 4 pillars on Mind Your Health: mind, muscle, mouth, medicine. And you basically touched on all of those things: mind, your sleep, your mental health; muscle, working out, moving it. That's what you're talking about with the wasting, right?
Yes.
Food, mouth, and then the medical piece. So really what you're saying is you can't really separate the brain from the body. Everything really is integrated, especially in what you're doing too.
It is.
And hormones, fascinating. And again, I think people will really enjoy this segment. So I just want to say, from Dr. David and I, thank you so much for joining us.
Thank you.
We appreciate it. We've learned a lot about how to.
Mind your health.
Thank you.
Mind your health.
You got to mind your health.
Mind your health.
Treat yourself.